we've created a dedicated role with health, so we've worked quite closely with health from the very beginning. We initially recruited a strategic health lead, really to help us navigate our way through the health system that's quite complicated to those that aren't part of it, and also really to make sure that they were on the journey from the beginning. That was for the whole system, so end to end. They were engaged in sort of the family help space right the way through to child protection. In our child protection team, we specifically focused in the early days on establishing the LCPP role. I have quite a strong view that as local authorities, if you're trying to create your LCPP role, work out what the interface is with family help and what that co-working arrangement looks like, at the same time as trying to establish dedicated resource in your multi-agency child protection team, that can be quite challenging. So we focused on sort of establishing the LCPP role, getting that recruited to, embedding the ways of working and making sure that we were comfortable with that. So for the first phase of our child protection team sort of going live, we were really only tapped into the existing health and police resources. It's only been really since the beginning of this year that we started to have the more detailed discussions around what the dedicated resource would look like. So we've got now a dedicated DI from a police perspective, and in health we are working closely with Warsaw because they're another pathfinder, they're a wave 2 pathfinder. We share an ICB, so it made sense for us to do some joint work, and that's the one thing I would urge people to do if there's opportunity, to consider geographical boundaries and where you can join up with other authorities. That can help, not just in terms of consistency but in terms of economies of scale as well, if you are looking at dedicated positions. We've gone for a safeguarding level nurse in our MacPT. We've also been really keen to emphasise that they are not there to do all the doing. They will not do all child protection work in that health space. They couldn't possibly. So we've really worked with our partners around, when we've got that dedicated resource, what will be the key areas of focus. So our first phase of this is around, they'll focus on cases that have been escalated, so where there's difference of opinions in child protection planning and the needs that objective or slightly more objective lens, where we need to challenge practitioners in terms of their thinking around what is significant harm. We have focused on same-day strats or urgent strats because we weren't getting those set up in a timely fashion, so we're using that dedicated resource from a health perspective to contribute to that. And also for child protection plans that have been open for over 15 months, which again is a cohort that we'd want to be making sure plans are progressing. So health are really engaged, and now it's just a case of waiting to see the real impact of that. Alongside that, we've got really good relationships with our paediatricians in terms of engagement at strats and obviously CP medicals and above. So yeah, that's really how it's working for us.